Remember that there is a handout that accompanies each talk I give in this course. I see the diagnosis and treatment planning process continuing through the whole course of treatment. Especially early in treatment, building a working alliance with your client is a critical predictor of a positive outcome. And the style that you use to develop a compassionate understanding of your client is an important contributor to the working alliance. An awareness of the range of symptoms and diagnostic categories helps you conduct a thorough assessment of the client, and an awareness of evidence-based treatments for various diagnostic categories helps you propose treatment strategies that have been found to be effective. The National Registry of Evidence-Based Programs and Practices is a searchable online registry of more than 280 interventions supporting mental health promotion, substance abuse prevention, and mental health and substance abuse treatment. The website is www.nrepp.samhsa.gov. Broadly speaking, treatment begins with the collection of data. Whether you have the client complete a questionnaire or an inventory, or you begin by asking questions in a clinical interview, you are gathering data for your treatment planning process. To me, during this process, the client is the expert on their condition, and you are the expert on psychological dynamics and on therapeutic processes. You synthesize the data that you have collected into a case formulation, which I believe should be shared openly and thoroughly with the client. It is very useful to obtain agreement with the client about the goals of treatment at this stage. It is the case formulation that drives the interventions that you propose and that you and the client choose to implement. I think of interventions as hypotheses about the correctness of the case formulation. As interventions are implemented, more data is collected, and some of the data is on the impact of the interventions on the client's functioning, testing the hypothesized case formulation. Additional problems may be defined, and the original formulation may be modified by the outcome of the interventions which have been implemented. This course on psychopathology focuses primarily on the data and formulation portions of this process. The DSM provides good information on the range and variety of psychological symptoms which people experience, as well as what symptoms tend to cluster together. For example, if a client presents with a depressed mood, the DSM suggests that you should also inquire about ability to experience pleasure in daily activities, appetite and changes in weight, sleep, energy, self-esteem, concentration, decision-making ability, feelings of worthlessness and hopelessness, and suicidal thinking. It is also important for you to know that many treatments, especially empirically supported treatments, have used the diagnostic categories to define the target population that is appropriate for the intervention. And so when you are able to diagnose a specific disorder, you are also able to recommend a specific treatment which has been found to work for that cluster of symptoms. One type of data that is essential to collect has to do with the nature of the problem or problems that the client is experiencing. The client may have been referred to treatment or even forced into treatment by someone else, but you are interested in the client's version and vision of their distress. Once you have the problem list, you will want to inquire about how long they have had each problem, whether the problem is intermittent or constant, how often it occurs, what might be triggering it, and how intense the problem is in the mind of the client. For many of my clients, I construct a timeline which includes each of the problems as well as major life events. This allows me to begin identifying possible life event triggers for episodes of the problem. Whenever you think about clients, whether you are writing or talking about symptoms, experiences, diagnoses, personality facets, test scores, history, or your impressions of them, it is essential that you be respectful. Respect is the cornerstone of a good therapeutic alliance and professional ethics. One component of a respectful relationship is confidentiality. Remember the old saying from World War II, "Loose lips sink ships." Be aware of who you are saying things to, where you are saying it, and where you are writing things down. The second component of respectful relating is professional humility. Recognition that all of the concepts we use to think about clients are limited. This is especially important in the course on diagnosis. The person is not a diagnosis. A diagnosis is a shorthand way to note that the person seems to have a set of symptoms that meet the diagnostic criteria. As the Buddha said, "When I say Ananda is going to the village for alms, I understand these 5 empty, effervescent processes of body, feelings, perceptions, thought, and consciousness are going to the village. But for convenience, I use the term Ananda." However well we describe a person and feel that we know the person, this description and understanding is limited. The third component of respectful relating is an awareness that people change. Our limited conceptualization of the person is a cross-section in time of their whole life, and our ability to predict what is going to happen in the future is very limited. A symptom or a diagnosis or a personality facet could be different. So when you are talking about clients, writing about clients, and thinking about clients, be aware of who could hear or see your thoughts. Recognize that you only have a part of the picture, and keep in mind that the person is a movie and will change over time. It is also useful to explore the factors associated with the problem getting better or getting worse. This can be a fruitful line of inquiry even when the client has reported that the severity of the problem is constant. Asking what is going on in their body, how they feel, what they are doing or not doing, places, time of day, role of friends, family, and co-workers, and thoughts that may be associated with improvement or with worsening of the problem can give some insight into potential therapeutic factors for the problem and may contribute to a change in how the client sees the problem. Exploring various areas of functional impairment which the client attributes to the problem helps the client feel like you understand the magnitude of the problem in their life. I think that some clients will spontaneously identify some areas of impairment, but a pointed inquiry often reveals other areas that have been impacted in their life as well. I always ask about tobacco, alcohol, caffeine, drugs, and exercise. When the answer is positive, I conduct a detailed inquiry into the amount and the timing for each of these behaviors.